Okay, let's move on to our next panel, and which are kind of specialty. Oh, no problem. Specialty. That was wonderful. Specialty clinical programs, and David Folsom will be the timekeeper and moderator, and while they're moving into space, I'll make a special request, as long as Igor's not listening. If you can, in your comments, and I know we're also excited about these wonderful programs, be as brief and concise as you can. That makes sense, and hopefully we'll be able to, before lunch, open it up to some an audience participation. So, Dave, the challenge is yours.
All right. Well, thank you very much, Sid. I think we have another wonderful group of clinical leaders here. And I had sent out an email ahead of time saying, hey, I did the math, and it looks like about 6 minutes each. Maybe we'll make a quick revision, cut it down a little bit, because it would be nice to have some questions. I thought Igor's question was actually really a great one. And he's banned from any more questions for the day, but others here may have some questions. Anyway, to start it off, I'm just going down the list in order. We have Ryan Trim, who heads up the alcohol drug treatment work at the VA.
Okay, well, hello everyone. Hope I've had a good symposium so far. This is very exciting to be here. So I am I've been the program manager for the Substance Abuse Mental Illness Clinic for about the past 9 years. I took over for Susan Tapert after my postdoctoral fellowship. So again, we just have a few minutes, so I just want to give a broad overview of some VA clinical services. So obviously, I know my clinic the best, our outpatient dual diagnosis clinic. So we service veterans with co-occurring disorders, primarily PTSD, depression, and substance use, typically outpatient groups, sometimes individual, a lot of CBT-based approaches, motivational interviewing. So we work very closely with the larger alcohol and drug treatment program, which is headed by John Sevick and John Grutner as well, both longtime providers in the VA system. ADTP obviously offers a wide range of services ranging from detox, to outpatient, intensive outpatient, residential through the SARTIP program. So VA's been around for a long time. Dr. Shuckett really kind of brought the ADTP into its what we know today, and as far back as the 70s, I believe. Has had a large influence from Dr. Antonelli. And so, we're looking at kind of ways to expand services. Just an initiative I'll point out is we were one of the champion sites in my clinic, in the SAMI clinic, for measurement-based care rollout back in 2016. So we've always been collecting data on our veterans, and this initiative helped us really shore up some of those processes to the point where we are able to more structurally and formally not only collect the data, but share the data with them on an ongoing basis. So we really, being able to integrate this, we have access to tablet technology. So about every 4 to 5 weeks, we're giving measures and providing that feedback to the individuals, both in the group-based settings as well as individual treatment planning sessions. So that's been something we're really proud of. We're also highly integrated with ongoing clinical research projects. One of my colleagues, Dr. Norman, may speak a bit about that, but she has an active VA merit trial that is currently active in our clinic. So in closing, again, I know we have a very short time, but I just want to do a hat tip to also one of the newer programs at UCSD, the Addiction and Recovery Treatment Center. This grew out of the Addiction Special Interest Group, which was formed back in 2015 or 16 by Drs. Antonelli and Judd. And is really an exciting new treatment center at UCSD. We hired Carla Marienfield about 2 or 3 years ago to head up that program, and it's been growing. I think right now they have 4 staff. They just, I believe, this past month started their intensive outpatient program. So I don't know if this is redundant with what I said earlier, but they definitely have a lot of exciting things going on at UCSD and our new addictions treatment there, the Suboxone clinic as well. So if you haven't heard about it, definitely check it out. But addictions we have so much talent in terms of our research and clinical services across the department in the VA, UCSD. It's really exciting to be a part of it. So if any questions or thoughts, happy to answer them. Thank you.
This works, but great job of coming through on time. Next we have Larry Malak, who's going to be talking about the community psychiatry work.
We've had the Gifford contract, the Oak County Clinic, the COD program for just recovery, kind of over the years, and now it's sort of taken on a new light, I think, a new partnership with the county, and there's some new exciting things on the horizon, it sounds like. But of stuff that's active now, we have the community psychiatry sort of training program that started as a partnership between the county and UCSD to really kind of get residents initially out of the VA and UCSD into kind of different, diverse, underserved populations and treatment settings. And that's now expanded to include the nurse practitioners and therapy interns and the faculty and staff who all go out to various sites. I think some of them I tried to jot down was we go to the crisis houses, the assertive community treatment teams that are working with the very sickest of the sick folks, finding people under the bridge or at their boarding cares, working with deaf community services, survivors of torture, Generate Hope, which is a human trafficking, sex trafficking program. The residents and the trainees love working with that group of women. They're really kind of inspiring. So it's been really a neat opportunity to get myself and all of the trainees out into the community to work with kind of the very underserved, underrepresented folks who can't quite come to UCSD necessarily with their insurances. So that's been great. I think in addition to that training model and that experience, we also have things like the Crest Program, which is a mobile hoarding program, which goes to the community and takes care of folks, particularly older folks who are dealing with hoarding and can't make it into the clinic or avoid coming into the clinic. The Second Chance Program, which is a prison sort of diversion dual diagnosis program in terms of taking folks who would otherwise be incarcerated for substance use offenses and having them get treatment and get a chance to really start their life in the outpatient setting while they're at a residential program and coming to UCSD for clinical treatment and care. And we have trainees who are embedded in that program, and the faculty there are really kind of dedicated to that work and to working with this really kind of unique population. Keep going on and on about various other things. The other kind of cool, I know Steve will talk about tele, but finding ways to deliver care to this group can be tricky. And one of the things that the residents really started actually and have gotten me to go down and volunteer with is the free clinic, which the students have kind of worked in, and the department, I don't know, we've had sort of haven't been too involved, I don't think, as far as the psychiatry department, but now being able to go down there and see a lot of undocumented folks who otherwise wouldn't have insurance and don't have access, and doing trauma screenings and doing kind of really innovative stuff down there has been a lot of fun too. So I will stop talking since we're running out of time, but there's lots of other stuff I could go on about.
Well, thank you very much, Larry. I think, bringing residents to some really innovative places for training has been fantastic. Absolutely. Next up, Steve is going to be pinch hitting for Jessica Thackerberry and talking about telepsychiatry.
Yeah, sorry. So Jess sends her apologies. She had a health type of thing, and so she couldn't be here this morning. So telemental health or telepsychiatry, interestingly, like not many people realize this, but telemedicine is its own sort of enterprise within the healthcare system. The very first grant and the very first contract under telemedicine was actually in psychiatry. And they initially got the grant to buy some machines, and those machines were sent out to what we call spoke sites or remote sites, and then the hub was our department. And it has grown from there. It was sort of a grant-based type of a project initially. Then in the last several years, it has morphed into more of a contract care delivery and innovative sort of programming. So even though other UCs have been more involved in the tele environment for the past 15 to 20 years, we're pretty proud of the fact that at current date, our department does actually more volume of telepsychiatry work than any other UCs. And we have very diverse type of services that we could deliver. So we could actually see telepsychiatry triage type patient care in emergency departments, on urgent care walk-in type services. We also have clinic-based type model where they directly schedule patients with us. We're also very involved in e-consults, which is a type of an asynchronous telemedicine modality of care. A lot of these sites have been remote, but as the laws have changed and we are now able to deliver care directly to the patient's smart mobile devices, we have started that project. So we kind of delineate this between sort of contract-based programs to distant spoke sites and to individual directly to patient type model, which was really started by Jess Thackerberry, and we have just recently figured out how to get the kinks out of the system as far as insurance reimbursements and things like that are concerned. And what's exciting about this moving forward, just in fact, even into just next academic year, is that we will integrate the so-called MyChart type visits, not only within our faculty practice in Hillcrest, but we'll start rolling this out across the department, and we'll also incorporate this within the resident clinic. So you could imagine a lot of younger patients, as well as younger colleagues, I should say, are very excited about this, because this is, part of the future of how healthcare is going to be delivered. The next phase, of course, is moving from telepsychiatry to teletherapy. So we will start to look into those models and how those should be reimbursed. And once the financials are sort of secure and our departmental policy on safety measures and things like that are set, then we should be able to expand quite rapidly. And so we're pretty excited that this will work very well. The other model that we'll introduce fairly quickly to support UCSD's primary care expansion is the so-called Itraq model, which is using telemedicine capabilities to actually directly put clinical care behavioral health specialists directly into primary care suites, so that they don't have to make additional appointments. We could directly pipe into those clinical settings and support those patients. And if they need be, ensure that they get follow-up care with specialty psychiatry, or be sent out to other case management or outside resources. So lots of exciting stuff.
Yeah, thank you, Steve. That is all really exciting. I'm looking forward to. I was just going to try and sign up my first patient to do a telepsychiatry visit using, basically secure FaceTime is what it is on your phone.
Right.
It's going to be pretty cool. Next up, we have the HERE program, and Judy Davidson is going to talk to us about that.
Yeah, so I think many of you know about the HERE program, a suicide prevention program for physicians that's now in its 10th year of operation. But what I'm going to focus on is the changes that have occurred over the past few years in that program. About 4 years ago, we had 3 nurses complete suicide at Hillcrest all in 1 year, and it kind of startled us and brought us to action. And we approached Sid and Bill Norcross and the others involved in HERE and asked if we could expand that service for the nurses and hospital staff. We wrote a grant to UCOP that was funded the project for about a year, and it was very, very successful. After that year, the executive team decided to continue the program on in perpetuity, so now it is a standard operating practice that our hospital staff is all offered the encrypted anonymous screening, and then the therapists for the HERE program work with the moderate and high risk and move them into treatment if needed. And just for the nurses, we've sent almost, I think, 60 nurses over 3 years into mental health treatment identified through this program. It's startling to us that the call for screening gets really high-risk people that are just under the surface, who are all insured and could have taken action before but didn't. About 80% of the people answering the survey have depression. 10% of the nurses answering the survey have had a previous suicide attempt, and 7% have active thoughts of self-harm. So we know the program is really needed for caring for our caregivers, the quadruple aim. We've been invited to speak all over the country about this because it's the very first nurse suicide prevention program ever anywhere. So we presented to the American Nurses Association that sets the standards for nursing practice. We presented to the Academy of Nurses, which sets healthcare policy for the country. We've been asked by the National Academy of Medicine, which used to be the IOM, to write a call for action about creating awareness around the risk of suicide in nursing. That paper was published last year. We've published our work in the most highly respected journal for nurse leaders, the Journal of Nursing Administration, Both our work with HERE and Sid and I together are working on a longitudinal study using the CDC MVDRS data set on the incidence of nurse, physician, and pharmacist suicide. We have the entire longitudinal data set since the day it was collected, and they keep sending us new data yearly. We're slowly chipping away at that. So we combine our presentations with the data and then the work of the HERE committee. And I'd like to call out that Sid Zizuk and Rachel Accardi and Courtney Sanchez do the work of the HERE committee. They do the lion's share of it. And then, of course, our 40-plus volunteers who often help with educational programs to raise awareness and group facilitated debriefings. We have organically sprouting out of this in an unplanned way, but it has now been enculturated into practice. We do launch group debriefings after clinical events that not just the hospital staff, but integrated the medical staff and hospital staff. Hundreds of people have benefited from over the past 3 years. And they've grown organically. People have requested them after they gained the confidence of the therapists in the program, the HERE program. And now there's a link built strategically between risk management and the HERE program so that when they have to go out and do a clinical investigation because something went bad in the workplace, they contact HERE, and HERE offers the management team an emotional process debriefing, which is very effective. And people love them. And those process debriefings are helping to chip away at stigma. People now know that they can call for help. They don't have to buck up and take it. People know that it's okay to have emotions surrounding the workplace issues, and they know they're not alone in those feelings. So we feel it's moving mountains to reduce stigma in the workplace. Lastly, I think I just want to talk about the fact that, maybe almost lastly, that just this week I received a call from the Tri-Council of Nursing. Imagine as if the AMA and the ACGME, the CEOs, called you and said, could we have a talk? Well, the Tri-Council is just that, and they've asked us to write an executive summary and proposal they would like to consider replicating the HERE program at a national level for the entire profession of nursing. Yeah. If I could just close with an emotional story. We did have, in year 2 of the program, a nurse called me and she said, Judy, she says, how do I get a hold of one of those HERE therapists? And I said, why? And she says, well, I'm working today with a suicidal physician. And I said, well, we got the HERE therapist, the HERE team on board, that the physician received the treatment needed. She called me back and she said, you know, without this expansion of the HERE program, I wouldn't have known there were resources available right at UCSD for the doctors that were in need. I wouldn't have known what to do, and I would not have taken action. We could have lost that life. So the expansion of the program across disciplines is really working. It's very much needed, and we're thankful that we've shared services together with you.
Thank you, Judy. You guys have been doing some very impressive work. Next up, we have Sonia Norman talking about the PTSD clinical services.
Thank you. So I'm going to start my story in 2007, which, as you probably know, PTSD is one of the newest diagnoses in the DSM since 1980. And what that means is that it's really in the last 30, 40 years that we've learned a lot about how to treat the disorder. And our initial understanding was that it was a chronic disease, kind of like diabetes. You could manage it, but you couldn't recover. So when people came to the VA or other places for treatment, the idea was that you would come forever. And that was the expectation we set for patients, was that they'd be seen, we'd stabilize them, and they'd be seen every 1 to 3 months ongoing. What we've learned since then is that you can recover from PTSD, and we now have excellent evidence-based treatment, psychotherapy, and medication that help patients recover. So in 2007 in our VA, our leadership very wisely decided to start a clinic expressly for veterans who had served in Iraq and Afghanistan, partly because we had one of the biggest populations in the country, but partly what that did was it allowed us a fresh start. So whereas many VAs were struggling with sort of this bathtub, if you think about water pouring in and the bathtub's plugged up and more water is pouring in and it can't go out, and so it starts overflowing. That was sort of what was happening in PTSD clinics because patients were coming in but never coming out. We were able to start fresh and start with an evidence-based model of treatment, which is weekly short-term treatment, lasting 10 to 15 weeks maybe, and then patients would move on. And it turns out that when you set that expectation from the beginning, patients are actually really thrilled that they don't have to come in for the rest of their lives and be psychiatric patients forever. And we made it clear that if you have a hard time again, we're here for another episode of care. The expectation is never that we'll just chronically manage you because you came in once. So I was hired to start this clinic and really wanted to set up this evidence-based model. This was before the VA started rolling out the training in evidence-based treatment. So I went to our Center of Excellence in Stress and Mental Health Leadership, and I said, hey, we're trying to really be leaders in PTSD research. I think that means we need to be leaders clinically too. And the leadership supported sending our psychologists. At that time, there was no training in VA. They sent them to Philadelphia, to Edna FOA, to places where people were developing the treatments, and they got the training, and we were able to do this. The other place where we were ahead of the game was in comorbidities. PTSD comes on its own 20% of the time. It's often comorbid with addictions, with depression, with even psychotic disorders, and we wanted people to get treatment even if they had those problems. And a lot of that was work based on my work with Pat Judd, really seeing how when you're working with any SMI or disorder, if people have trauma and PTSD on board, it's harder for them to get better. So we wanted to treat the PTSD too. So in 2008, the VA went through a massive policy transformation, and suddenly there was policy that every veteran had to have, with primary PTSD, had to have an evidence-based treatment offered to them, prolonged exposure or cognitive processing therapy, and that comorbidities such as addiction could no longer be a barrier to getting these treatments. We were already doing this, and we were one of the only VAs already doing this, and there's a lot of ways that we got recognition for that. I really, even though this is a clinical panel, I really can't talk about this program without talking about education and research because they are so closely coupled in what we do. So we very early on started training trainees in these treatments who otherwise had very little opportunity. They would go to VAs and just get treatment and or training in this long-term model, which attracted a lot of excellent trainees who then stayed on, did research, became part of our faculty, and that continues. And we started a weekly seminar in 2007 that not only drew the trainees, but drew faculty from all over our department, drew people from the community, like police officers who wanted to learn about trauma and its impact, and that continues. We were a measurement-based care clinic from the start, so that's an initiative that's VA-wide now, but we were always collecting PTSD, depression, substance use measures pre and post and during treatment. We collected additional measures as well with an ongoing IRB, and that has allowed us to publish, for example, Tanya Messino, one of our psychiatrists and faculty members, was interested seeing a high rate of obstructive sleep apnea. We collected screening information on obstructive sleep apnea, and we published it, saw a very high relationship with these young veterans with PTSD, even the ones that weren't obese or didn't have some of the classic risk factors. That was picked up by Medscape and for a press release and got tons of attention. We collected measures of reintegration stress and saw a relationship with suicidal ideation. That was the first study to show that also got a lot of attention. In 2012, I left my position and took a VA-wide position with National Center for PTSD, where I went around to other VAs and run a VA-wide consultation program to help all VAs do what we've done in San Diego. It's now 3 generations past my leadership, and there isn't a week that I'm not talking with a facility and don't say, well, here's how we solve that problem in San Diego. To close, I'll say that one of the things I see working now, having this wider perspective, is that it takes the whole system to do what we've done here, and you need supportive leadership. You need a culture that supports this. You can have an individual who's all gung-ho for anything, but it won't work if you don't have a system that supports this. And we always have in the most sort of foresightful vision sort of way.
Thank you very much. That's very impressive, and I think the idea that having a whole system kind of backing you up on these things. That was the same thing that Judy said. I think same thing we heard regarding the addiction treatment at the VA too. Thank you. Lisa Delano-Wood is not able to be here today, so we will move to Tina Bezai, who's going to pinch hit for Niloo Afari and talk about VA clinical services.
Thank you. Thank you for including me. So I just want to say I'm the Associate Chief of Psychiatry at the San Diego VA. I am filling in for Niloo Afari, who is an amazing woman and leader. She is the Associate Chief of Staff for the Mental Health Care Line at the VA San Diego. And the care line includes, essentially, it was a merging of different service lines, includes psychiatry, psychology, social work, nursing, to have really a coordinated approach to care for patients. I just wanted to say, I'm going to try to channel Niloo and say what she wanted to say in terms of innovative programs, kind of highlights. I'm going to be very brief, so we have some time for questions. I just want to say the VA San Diego has a very long history of a strong affiliation with the Department of Psychiatry at UCSD. It's a very important relationship. Some of the current innovative aspects, I'm just going to outline a few. And I want to mention on a systems level, the focus is on access, much like it is at UCSD. The focus is also on it being veteran-centric. We also have a strong focus on staff retention and morale and wellness. And this has really led over the last, let's say, 4 or 5 years to really the development of a strong provider, kind of core provider group where we're able to develop our programs further through that. One of the innovations that nationally that the VA is involved with is the development of collaborative care. At the VA, we call that primary care mental health integration. This is well developed at the VA. This is where you have an interprofessional team. You have a nurse care manager, a psychiatrist, a psychologist, embedded within the primary care team. They are part of that team. And they are providing improved access, brief treatments, with the idea being population management, education to the primary care teams, and referral back. And so that, in that kind of innovation, we are well developed. We're excelling at all the metrics, and we're one of the leading sites in the country. A second innovation at the VA San Diego is the Telemental Health. And so we had a history we were a regional center for that. And historically, Telemental Health used to be patients would have to go into a location, they'd have their computer screen there, the provider would be somewhere else within the VA with a computer screen. And so this really has evolved quite a bit over the years. Now what's going on at the VA is really the patients and the provider, there's an email link that they both can click on, and they're in an encrypted video kind of meeting. They can be anywhere, so the patient could be at home, the provider could be at home. And so this is really a very exciting technology. It has both, let me say, the collaborative care and the telemental health have increased, there's increased patient satisfaction, increased provider satisfaction, improved access, and really critically for the VA San Diego is it solves some of our space issues. And so what we don't have is a lot of open office space. And so allowing this kind of flexibility really is a innovation. The VA is planning, I believe, by 2021, that all of the providers, some component of their clinical practice will be via tele. And so right now the push is to everybody have a clinic set up, everybody have access to the technology, and to start utilizing it. So that's, and I will just say also that San Diego VA is the second in the nation with providing tele treatment. The only one that tops us is Charleston, which is the national hub for the entire program. So we are really showing leadership there. Ryan and Sonia mentioned measurement-based care. So the VA is very focused on providing evidence-based treatments and providing measurement-based care. VA San Diego developed a key tool, e-screening, which is used in multiple clinics. And so we use these measurements to assess how the patient is doing, have target symptoms, goals of treatment, and in terms of symptoms and quality of life. And so that is proving to be very effective in terms of interventions. Last thing I'll mention is the Aspire Center, which is our residential PTSD treatment for veterans with post-traumatic stress disorder and homelessness. And this is a national model for residential treatment for PTSD symptoms, and it's been shown to reduce emergency room visits and psychiatric urgent care visits and et cetera. So that's the information Niloo wanted to convey to you all. We're excited to continue our close relationship with UCSD, and that's all. I'm opening it up for questions.
Well, I want to first just thank everyone. I mean, I think across the board we have some amazing, innovative programs. It's really impressive to get a chance to sit back and appreciate all the cutting-edge things that people are doing here, the way we're leading in so many different ways, and and both providing great patient care in the process, as well as training the next generation of clinicians. So, thank you all. I would like to. I see someone beat Igor to the mic. So.
I did. I got up quickly before Igor could.
Sonia, please.
So, I had to pick up, of course, on the sleep part. So, Sonia, I think it's fabulous what you've been doing, looking at sleep in general, not only just sleep apnea and PTSD. And I think all the clinical services need to learn from that example, because sleep affects sleep problems are comorbid with all psychiatric disorders. And often if you treat the sleep concurrently as you're treating your different psychiatric disorders, you'll get a better response to the psychiatric disorder. So I want to encourage you. At minimum, there are questionnaires you could be using. I'm happy to advise you on that. But I would encourage all the clinical services to start thinking about sleep if you aren't already.
I mean, certainly that's, we see that over and over again, as sleep is both kind of has a life of its own and has such a great impact on successful treatment of the rest of the person.
So I've got a question. This is incredible. Thank you so much. And you also brought us back on time. So good job. My question is directed to Arnold. Did you ever in your wildest dream, back in 1969, think that this was what you were starting?
It's so gratifying to see the ramifications and the diversity. And it was a fantasy, of course. I came from psychoanalytic roots and the purity of not saying anything until you had an intervention to make. And to see almost a social movement emerge that was sophisticated in this way has been an amazing few days. I have a feeling that it says if you can start along the right path, maybe it can go as spontaneously. But it's hard to imagine this kind of diversity and social ramifications, which were in a way not part of psychiatry. And now psychiatry has become a thing that I'm standing back and listening and looking and wondering what the field is. And I suspect maybe the word psychiatry won't be as prominent as I don't know whether this is going to be neuroscience, applied neuroscience. I don't know whether this is going to be social movement and development. But it's a wonderful thing to see, and I've been so gratified. You all are to be very much appreciated. And maybe you don't fully realize how revolutionary you've been. Maybe from my perspective, it's like a new world, and it's just wonderful to see. And thank you very much for allowing me to, maybe I ought to thank God for allowing me to live long enough to see such wonders. Thank you.
Yeah, I just wanted to say that my practice has become a telepsychiatry practice, even though I wasn't planning on it. I mean, people will get caught in traffic jams, and instead of, you know, it takes 3 months to see me, you know, and so instead of saying, no, I'm not, you have to reschedule, we just talk over the phone, and we do what we have to do. And with some people, that's been true of Facebook, with worse difficulty of people traveling and with their more, their schedules that are more packed, especially in children and adolescents. You know, I'm competing with soccer teams and stuff to get FaceTime with the kids, and I certainly always try to have one-on-one, but a lot of times I'm doing a lot of, and have been for many years, a lot of telepsychiatry, i.e. telephone, and now more FaceTime. So I think the more we can find out about that, how to most practically deliver, it would be very helpful, and it would solve a little bit of the problem of not having enough psychiatrists.
RP, then Igor.
Thank you so much, all of you. A quick shout out to the HERE program. I'm RPM, the psychologist on the burn service, and the burn service has a bit of a sad connection with the HERE program. One of the very tragic events that sort of spurred us to think and talk about physician depression and suicide was the very untimely suicide of Dr. John Hansborough, who was the attending on the burn surgeon years ago, and he was larger than life, and his suicide left us all asking why. And at the time, nobody talked about physician depression and suicide in the way that they do now because of the HERE program. And so thank you. And thank you for continuing to service the medical teams, including the burn service, which not infrequently calls upon the HERE program to do these debriefings. Difficult things happen on burn, difficult, tragic patient outcomes and things like that, and our staff truly are impacted by it. So thanks again for the hard work that you do.
Let me comment on what would be amazing 50 years ago, which is the camaraderie and collaboration of psychology and psychiatry. Just as a little piece of background, when I came here, I wanted to start a seminar in elementary psychopharmacology for the psychology department, and it enraged the department. The department at the time was a learning theory, mathematically oriented, sophisticated academic thing, and didn't want to have anything to do with that sort of business. I got a call from the president of the American Psychiatric Association, who will go nameless, to complain about the fact that I had made such an offering, that we should keep drug knowledge away from psychologists. And we can giggle about it now, but it was vituperous at the time. And as I continued to push for collaboration with the psychiatry, George Mandler and Jean Mandler, his wife, was somewhat supportive, but the rest of the department, like Norman Anderson, an elegant social psychologist and mathematician, was enraged. It's like dirtying up his lawn or something like that. So it's an amazing thing to see the fellowship, and should be commented on.
Thank you. Igor.
I know you banned me from any further comments, but you know, what can you do to me? I just wanted to comment on the VA-UC synthesis, synchrony, and so forth, because I was actually, when Arnold recruited me, I don't know if you'll remember this, he gave me a choice. He said you could be at the university at the bank building, which he was just buying, or you could be at the VA. And I said, I want to be at the VA because the hospital was just opening its doors and it seemed very exciting. You had to run over clods and things to get into it. And it didn't have a mental health clinic yet and so forth. Anyway, the point, though, is that we've always had a very close relationship with the VA and the university. And what I would like was stimulated by the talks today is that the VA has made a lot of advances in certain kinds of evidence-based care, in the way you monitor, record, track, feedback, and change. And also in the mental health area where the VA has had enormous strengths. And I'm just hoping that our clinical division on the university side will continue to work very closely to learn from the VA's experience. And of course the VA also has something to learn from the other side of the street as well. But so that's actually my plea, is that we keep learning from you. And the other way around.
Great, I think that's great advice. Both the ongoing collaboration between psychiatrists and psychologists, which I think other people have said, we don't appreciate how well it works here because it doesn't always work that well elsewhere, which is fantastic. And then also between the UCSD and the VA. Any final comments or thoughts from our panel?
I had one. When you mentioned that, Igor, I realized I left out one point as I was channeling Niloo. And one thing that the VA, and Sonia, I think, was involved in this quite closely, has developed is a model for video teleconferencing to deliver evidence-based psychotherapy. And Steve, you were mentioning developing this at UCSD. And so I think there is a lot we can learn from each other. I think what happens is both the VA and Department of Psychiatry, UCSD, and we've grown so large. And so how do we kind of keep communication channels where we can kind of work on these things together? I think that's the challenge. We now have, I won't go into the numbers, but we've grown each year. And so kind of getting all the faculty to be connected would be the challenge, I think.
Yeah, I think we've gotten bigger and everyone's really busy, and
yeah,
so making that connection, it seems harder than it should be. Yeah, absolutely. Well, I want to thank everyone on the panel here. You did a wonderful job, and certainly on your work day in and day out, very impressive. So thank you very much.
Thank you.